Well, hello. My name is Ellie. I am a nurse practitioner in general GI in Boston. I work at Beth Israel, and today we're just going to dive into the growing world of metabolic dysfunction-associated liver disease, or better known as MASLD. So I guess grab your coffee or your charting station and let's get into it. So I think it'd be important to start off with MASLD versus MASH and why it matters. So I think first, let's clarify what we're dealing with. So simple steatosis or MASLD is that fat accumulation of the liver in the liver. And previously it was called NAFLD or non-alcoholic fatty liver disease, but we're changing that nomenclature since 2022 to include that metabolic criteria. So really making sure, if patients meet 1 out of 5 criteria based on those criteria called obesity, you're really looking at, hypertension or whether they're on an antihypertensive medication. You're looking at their cholesterol and then type 2 diabetes. And then the big piece is ruling out whether they have excessive alcohol intake or not. So MASLD is without that inflammation, or fibrosis that defines that progression. So I like to think of it kind of like as a warning light, like the engine's not totally damaged yet, but something's just not right, not running. And then you have MASH, which is metabolic dysfunction-associated steatotic hepatitis, meaning the liver has that real attack on it. There's hepatocellular injury, there's inflammation, and more critically, potential for that fibrosis that can progress to that cirrhosis. And, clinically, that distinction matters because MASH carries that risk of the progression of liver failure, hepatocellular carcinoma, even death. So it's really important to first identify those patients early and prevent that from happening. So that kind of brings us into the next segment, where non-invasive tests or NITs come into play. So really we're talking about, those non-invasive testing and what do they tell us? So there's 2 main categories, the serum-based and then the image-based. So starting with serum-based, the pros of those are they're accessible, inexpensive, and based on labs we're probably already ordering. So the best thing to start with, I think, is the FIB-4 score. And I think a lot of, people in GI have heard of this. It's based on age, AST, ALT, and platelets. And it kind of gives us that fibrosis estimate. That cutoff we're looking for is 1.3. So greater than 1.3, you're thinking, hey, maybe we have some advanced fibrosis going on, and less than, it's less likely. And then you can do an ELF score, and it's a proprietary panel that directly reflects fibrogenesis. A lot of places don't have access to those ELF scores, so I usually kind of go off that FIB-4. Again, these are all, relatively low cost, easy to calculate, especially the FIB-4. A lot of electronic health networks can just pop that right into a calculation. And then the biggest thing is primary care or endocrine people can really use those in their settings. And then I guess just thinking about limitations with those serum scores, sometimes they can be less accurate if you're thinking about like really young patients or really old patients. And then, again, sometimes that FIB-4 is not really reliable in younger patients under 35 or over 65. And a lot of times they can't really quantify that steatosis and don't work well in isolation. And then let's move on to that image-based non-invasive testing. So the gold standard that a lot of people think about is that FibroScan. And really it gives us 2 numbers, the CAP score, which is the score for steatosis or that fat, and then that KPA value for fibrosis or sort of managing the degree of stiffness. You could also think about an MRE or an magnetic resonance elastography. It's more accurate, but less accessible and usually a higher cost. So just kind of quickly talking through the pros of images, that FibroScan really does give real-time liver stiffness and fat content. So it's, again, great for stratifying risk. And then the MRE, I guess it technically could be the gold standard of the non-invasive. And it's particularly useful if you're not really sure about the causes or if you're even considering possibly a biopsy. So it could be helpful in decision-making. Limitations, sometimes the FibroScan can be limited in really obese patients or people that have ascites. And again, this can be a little bit higher cost. So you want to think about a lot of like rural settings don't really have access to those. So they're probably going to want to go for the more serum-based. So let's kind of like make sense of using these non-invasive testings in the clinical setting. How do we use these in real life? Let's say your patient has elevated liver enzymes, type 2 diabetic, maybe they have a BMI of 36. You're like, okay, let's do the calculation. Let's do a FIB-4 score, and it comes back borderline. You're like, great. It's around 1.3. You just stop? No. Okay, let's take a step back, zoom out. You want to look at LFT trends, right? Like, is AST consistently higher than ALT? Sometimes that's concerning. Let's look at their comorbidities. Do they have diabetes? Do they have hypertension? Are they on a hypertensive medication? Do they have high cholesterol? Like, are they on a statin? All of these things are putting them at risk. So then maybe put together the non-invasive testing. Maybe you pair the FIB-4 score and get in the FibroScan if available, and then look for the red flags. If the FibroScan is showing greater than 8 kPa, you're definitely like raising a red flag right there. And then lastly, I think it's important to really look at the patient in front of you and ask more questions, like get a history. Are you gaining weight? Like, do you have significant fatigue? Like some other signs that fibrosis could be progressing. So I just want to quickly talk about some key numbers that we need to be mindful as APPs. So FIB-4, we talked about that threshold of 1.3 under the age of 65, low risk, monitor it, average risk, no diabetes, no hypertension. You could probably look at that every 2 years. But if they have like 1 or 2 metabolic risk factors, you're going to want to do that a little bit sooner, usually like every year. If they're at like a 2.6, or 2.5, they're considered higher risk. Primary care is going to want to refer them. And then, a lot of times these patients, we're seeing them fall like between 1.3 to like 2.6. That's like intermediate zone, our favorite. At that point, definitely consider that FibroScan if it's available to you. And then again, those cutoffs for FibroScans, if it's less than like 7, low risk for advanced fibrosis. If it's, greater than 8, you're like thinking about that moderate, advanced fibrosis. So I guess, kind of a few takeaways, just to kind of close out this, this short little podcast. Just things to remember, MASLD common. It's more common than we think. And unfortunately, about 33% of people in North America have some degree of MASLD. So I really want, us to be mindful of those cardiovascular risk factors, really asking about patients about even their family history of liver disease, all of that plays into your role. And then non-invasive testing can definitely help risk stratify without the use of biopsy, but they always need to be interpreted in context. And then, I think that the FIB-4 is an excellent first step, and educating our primary care colleagues could be really helpful to help sort of triage these patients into whether they need advanced, hepatology follow-up or not. And then lastly, know those cutoffs when you get a FibroScan, and never, ever don't hesitate to refer if things get a little crazy or you're not really sure. Your hepatology or gastroenterology colleagues would be more than happy to kind of look through things more. So I just kind of close it out. Your job as a nurse practitioner isn't just to spot liver disease. It's definitely to connect those dots before fibrosis flies in, and you can make a real impact. So thank you.